Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
Since this episode aired on April 30th, 2024, there have been several new trials investigating the management of early-stage cervical cancer, including sentinel lymph node biopsy, conservative surgery, and adjuvant treatment. We've split this early-stage cancer episode into two parts. Today we'll review epidemiology, diagnosis, and staging. And in part two, we'll discuss surgical technique, including mode of surgery and fertility-sparing procedures. We hope you enjoy this updated episode. This episode is the first in our series on cervical cancer. Today, we're going to be discussing early-stage cervical cancer. We'll be discussing management of FIGO 2018 stage 1A, 1B1, 1B2, and 2A1 disease. Sydney, what are our learning objectives for today?
Our learning objectives are to recognize the high incidence of cervical cancer and how this disease disproportionately affects developing countries, people of color, and communities with limited access to health care, to acknowledge that the biggest risk for development of cervical cancer is persistent human papillomavirus infection, to understand that cervical cancer staging was updated in 2018 and acknowledge the changes in the new system.
Let's get started.
Cervical cancer is the third most common gynecologic cancer in the U.S., with a projected 13,820 new cases and 4,360 deaths in 2024. Worldwide, cervical cancer is the most common gynecologic cancer, with 350,000 deaths in 2022, 94% of which occurred in low and middle income countries. Overall, the incidence of squamous cell cervical cancer is decreasing, largely due to effective screening and human papillomavirus vaccination. Despite this, in the U.S., cervical cancer disproportionately affects patients of Latino, Black, and Asian descent. Unlike the declining rates of squamous cell cervical cancer, rates of adenocarcinoma and adenosquamous carcinoma of the cervix are increasing. As these cancers tend to occur higher in the cervical canal, they are less likely to be picked up by cervical cytology, and a screening method which incorporates HPV testing may be a more effective strategy for detection. Maya, can you briefly discuss some of the risk factors for cervical cancer?
By far, the biggest risk factor for development of cervical cancer is persistent HPV infection. Incidence of cervical cancer is related to the prevalence of HPV. In countries with high rates of cervical cancer, the prevalence of chronic HPV is 10 to 20%, while in countries with lower rates, the prevalence is 5 to 10%. HPV vaccination targets strains of HPV that are responsible for both squamous cell carcinoma and adenocarcinoma, but doesn't address the 5% of cervical cancers that are HPV independent. We won't review cervical cancer screening guidelines in this episode, but we want to highlight that in May of 2024, the FDA approved the use of self-collected samples for HPV testing using the BD OnClarity HPV assay or Roche Cobas HPV test. Many of the risk factors for cervical cancer are related to the increased risk of HPV, including early onset of sexual activity, higher number of sexual partners, history of STI, early and increasing parity, and immunosuppression. Other risk factors not related to the increased risk of HPV include smoking history, low socioeconomic status, which is likely related to decreased access to vaccination and screening. Smoking specifically increases the risk of squamous cell carcinoma, and smoking cessation is crucial to allow the immune system to effectively fight HPV infection and associated dysplasia or cancer. Increased risk with OCP use is controversial. In one large analysis, there was an increased risk, with the highest risk while using OCPs and declining to the risk level in the general population by 10 years after OCP cessation. But in another systemic review, there wasn't a significant association with OCP use. There's similarly conflicting evidence regarding the differential impact of OCP use in the development of adeno versus squamous carcinoma. And finally, there's evidence of genetic risk factors for cervical cancer, which aren't completely explained by environmental exposures, although these aren't completely understood. Sydney, what things can impact the prognosis of cervical cancer?
Stage is the most important prognostic factor for patients with cervical cancer. Lymph node status, which influences stage, is an independent prognostic factor. Involvement of the lymphovascular space is associated with prognosis, but there's controversy over whether this is an independent prognostic factor. HPV status also impacts prognosis. Patients with HPV positive disease tend to have a better overall survival compared to HPV independent disease. About 80% of cervical cancers are squamous, and the remaining 20% have adenocarcinoma or adenosquamous components. In adenocarcinomas, pathologists can use features like luminal mitotic figures and apoptosis to distinguish between HPV-dependent and independent lesions. In HPV-associated endocervical adenocarcinomas, depth of invasion is difficult to determine, so the Silva classification system is used to classify patterns of invasion. Pattern A indicates a non-destructive invasion, Pattern B describes locally or early destructive stromal invasion, and Pattern C describes diffuse destructive stromal invasion. These three patterns may better risk stratify tumors and predict recurrence risk. Often, diagnosis of cervical cancer will occur prior to a patient being seen by a gynecologic oncologist. Once a patient has a diagnosis of invasive carcinoma, what's included in the workup?
Great question. Like you said, most of these will first be diagnosed by primary care doctors or OBGYN specialists. Early stage disease is often asymptomatic and picked up at routine screening, but patients can have watery vaginal discharge, postcoital bleeding, or other intermittent spotting. To determine the appropriate management, accurate staging of cervical cancer is essential. This evaluation process should include an H&P, CBC, renal and liver function tests, and should consider HIV testing and smoking cessation counseling if applicable.
The most recent staging system, which we'll use throughout this episode, is the FIGO 2018 staging. Remember that, as in other disease sites, many cervical cancer trials were conducted using old staging systems. When interpreting what individual trials mean for your patients, it's important to reframe the results based on current staging systems to know whether the results apply to your patient. As we mentioned, early stage cervical cancer includes FIGO 2018 stage 1A, 1B1, and 1B2 disease. FIGO stage 1A disease includes tumors with a depth of invasion less than 5 millimeters, with subdivision to stage 1A1 disease for depth of invasion less than 3 millimeters, and 1A2 if depth of invasion is 3 to 5 millimeters. Stage 1B disease includes tumors with greater than 5 millimeters depth of invasion and less than 4 centimeters widest dimension, with substage 1B1 for tumors less than 2 centimeters. Stage 2A1 disease is an interesting stage that gets treated the same as early stage cervical cancer and describes disease that involves the upper 2/3 of the vagina without perimetrial invasion and with an overall tumor diameter of less than 4 centimeters. The presence or absence of LVSI does not impact the FIGO stage, but it does impact prognosis. We'll talk later about how to incorporate the presence of LVSI into treatment decisions. Okay, so that should help clear up our discussion. Maya, how do we go about determining the stage of disease?
In the FIGO 2018 cervical cancer staging system, clinical exam, surgery, and/or imaging can be used to assess the final stage. And FIGO recognized all of these modalities as valid for surgical staging. Additionally, no specific procedure like a cystoscopy or proctoscopy is required. Clinical staging is based on exam. This might be a more accessible staging system in low resource settings and performs best in the setting of microinvasive disease or more advanced stage disease. Clinical staging can avoid surgery in patients who aren't candidates for surgery. For disease that is apparently stage 1 on exam, imaging with pelvic MRI can be utilized to assess local disease extent and location of the tumor, and PET-CT for stage 1B plus disease is recommended to assess for nodal and distant spread. Other imaging can be considered based on symptomatology. It's important to perform imaging of the upper urinary tract for any cervical cancer that's more advanced than microscopic disease. If there's concern for bladder or rectal invasion, then a cystoscopy or proctoscopy can be helpful pieces of the evaluation puzzle. Use of imaging and procedural modalities will also depend on access to resources. Surgery is another important tool for staging. Patients often present to the GYN oncology office with results of colposcopic biopsies. While these, in some cases, may provide sufficient information for treatment planning, a cone biopsy is indicated if invasion has not been definitively established or if an accurate assessment of depth of invasion to establish microinvasive disease is needed. Owen is generally preferred to LEAP due to an ability to orient a non-fragmented specimen and concern with charring of the margins with a LEAP. The shape of the cone biopsy should be tailored to the patient and the disease, with longer cones for adenocarcinoma, where invasion in the endocervical canal is more likely. On the pathology report, make sure that margin status and LVSI are documented, as these will impact treatment decisions. If patients undergo hysterectomy as part of their primary treatment, final pathology may also alter the patient's final stage. What about lymph node assessment, Sydney? Is it necessary in cervical cancer?
Good question. Lymph node involvement is part of the staging system for cervical cancer and confers worse prognosis. A lot of the information we have about prognosis for cervical cancer comes from GOG 49, which was a prospective study of 645 patients conducted over 21 years. In this study, patients with apparent stage 1 disease underwent radical hysterectomy and pelvic and periaortic lymph node dissection. Those with extrauterine disease, including periaortic metastases, were excluded. After this surgery, those with stage 1B disease, which in this study was stage 1 squamous cell carcinoma with greater than 3 millimeters depth of invasion, and possibly positive or negative pelvic nodes, given that involvement of pelvic nodes wasn't considered in previous staging system. These patients were followed to determine prognostic factors for recurrence and pelvic lymph node positivity. On multivariate analysis, risk factors for microscopic pelvic lymph node metastases were LVSI, depth of invasion, parametrial involvement, and age. Pelvic lymph node positivity was significantly associated with disease-free interval, with a 3-year disease-free interval of 86% if nodes were negative versus 74% if positive. Independent prognostic factors for disease-free interval included tumor size, LVSI, and depth of invasion. There are several ways that we can assess whether lymph nodes are positive for metastatic disease. Imaging, as described previously, can be very helpful for evaluating lymph node metastases, specifically with whole-body PET-CT. Whether or not to perform surgical lymph node assessment depends on clinical and imaging assessment of stage. For patients with stage 1A1 disease, there is less than a 1% risk of lymph node metastases, and lymphadenectomy is not necessary unless LVSI is visualized in biopsy specimens. Lymph node evaluation is recommended for stage 1A2 to 2A1 disease given higher rates of lymph node metastases. Maya, what are our options for performing a surgical lymph node assessment?
Options for nodal assessment include pelvic and/or para-aortic lymphadenectomy, debulking of suspicious nodes, or sentinel lymph node biopsy. Sentinel lymph node biopsy, as in other disease sites, is emerging as a possibility for detection of low volume and microscopic metastases while minimizing sequelae of full lymphadenectomy. In meta-analyses, sentinel lymph node detection rates have ranged from 89 to 92%, with sensitivity around 90%. Sensitivity of sentinel lymph node biopsy appears to be much higher when limited to tumors less than 4 centimeters in size, and even better with tumors less than 2 centimeters. It's also more sensitive when imaging is negative for metastases, when lymph nodes are detected bilaterally, and with the use of ultrastaging. If all of these factors are present, the sensitivity has been reported at 99%. Both blue dye and radiocolloid tracer, as well as ICG, appear to have similar rates of detection. In a phase 3 trial by Frumovitz published in 2015, ICG identified more sentinel lymph nodes than traditional blue dye in both cervical and uterine cancers. Several studies have evaluated sentinel lymph node biopsy prospectively for cervical cancer. The Cervical study series started with Cervical 1, published in 2011. This was a prospective, non-randomized trial which included patients with up to FIGO 1994 stage 1B1 disease, meaning up to 4 centimeters of tumor. The Cervical study series provides prospective data on the safety and efficacy of sentinel lymph node biopsy in early-stage cervical cancer. The first Cervical study, published in 2011, was a prospective, non-randomized trial which included patients with up to FIGO 1994 stage 1B1, so this meant up to 4 centimeters disease. Sentinel lymph node biopsy was performed in all patients using blue dye and radiotracer, followed by pelvic lymphadenectomy and resection of any other sites that had a sentinel lymph node map. In this study, nodes were mapped in 98% of patients, but only bilaterally in 76%. The sensitivity of sentinel lymph node biopsy was 92%, and the negative predictive value was 98%. In patients with bilaterally detected sentinel lymph nodes, there were 0 false negatives. Additionally, sentinel lymph node mapping identified sentinel lymph nodes that wouldn't have been identified performing a standard pelvic lymphadenectomy. Cervical 2 was a follow-up randomized controlled trial published in 2021. The study had similar initial inclusion criteria and also used a combined detection method, but patients were only randomized if they had successful mapping of sentinel lymph nodes bilaterally and if the nodes were negative in the case of intraoperative frozen section. And the intraoperative frozen section wasn't done in all the patients. Patients in the study were randomized to sentinel lymph node versus sentinel lymph node and pelvic lymphadenectomy. Postoperatively, if the final pathology demonstrated positive metastatic nodes, then patients underwent reoperation with a full lymphadenectomy. So it's important to note that none of the survival data from this study will reflect the prognostic implications of mapping versus resection of non-clinically enlarged nodes. Their primary endpoint was morbidity related to the lymph node dissection. Rates of postoperative neurologic symptoms were improved with sentinel lymph node biopsy, as was lymphatic morbidity, but rates of lymphedema specifically weren't different. The 3-year recurrence-free survival didn't differ between the groups. And remember that anyone with a positive sentinel lymph node had a reoperation for a full lymphadenectomy. The 4-year follow-up was published and again showed no difference in disease-free survival. Cervical 3 is an ongoing international RCT, which is also comparing sentinel lymph node biopsy alone to sentinel lymph node biopsy and pelvic lymphadenectomy, with primary outcome of disease-free survival and health-related quality of life, and a secondary outcome of overall survival. This will be the first prospective overall survival data that we get regarding sentinel lymph node biopsy in cervical cancer, and enrollment for this trial was completed in May of 2024.
The Syntax trial was a single-arm prospective non-inferiority trial published in Nature Cancer in 2025. This study included 731 patients with FIGO 2018 stage 1A1 disease with LVSI to stage 1B2 cervical cancer. Participants underwent sentinel lymph node biopsy followed by either hysterectomy or trachelectomy, radical or simple. Those with failed mapping, unilateral detection, or intraoperative sentinel lymph node metastases were excluded from the intention to treat population, culminating in a total of 594 included individuals. Sentinel lymph node metastases were found in 82 patients, 12%, with 56% detected intraoperatively and 44% identified only on postoperative ultrastaging. At 2 years, the recurrence rate was 6%, meeting non-inferiority relative to the 7% benchmark rate. 2-year disease-free survival and overall survival were 93% and 98%, respectively. These findings demonstrated that sentinel lymph node biopsy without standard pelvic lymphadenectomy does not increase recurrence risk in appropriately selected patients, and that ultrastaging identified approximately 44% of node-positive cases that would have otherwise been missed by conventional pathology.
The Phoenix 1 study was also published in 2025 in the New England Journal of Medicine. This was a randomized, open-label, non-inferiority trial. The study included 838 patients with FIGO 2018 stage 1A1 with LVSI, stage 1A2, 1B1, 2A1 disease with tumors less than or equal to 3 centimeters. patients underwent a sentinel lymph node biopsy with intraoperative pathologic assessment. If frozen section was negative, they were randomized to full lymphadenectomy versus no full lymphadenectomy, followed by a radical hysterectomy or a simple hysterectomy if they were stage 1A1. They had predetermined criteria to assign need for adjuvant radiation. Their primary outcome was disease-free survival at 3 years, which was 94.6% in the lymphadenectomy group versus 96.9% in the sentinel lymph node biopsy group. 3-year cancer-specific survival was 98% in the lymphadenectomy group versus 99% in the sentinel lymph node biopsy group, with a hazard ratio of 0.37 and a confidence interval of 0.15 to 0.95. This survival detriment to full lymphadenectomy was only demonstrated in patients undergoing MIS procedures and not in the open surgery group. It sounds like these studies have had results overall in favor of sentinel lymph node biopsy. But is there criteria for which patients can undergo sentinel lymph node biopsy? For example, is there a tumor size limit?
Great question. As we mentioned, the Cervical studies included tumors up to 4 centimeters, but didn't provide any analysis or results of tumors by size in terms of outcomes. Previous studies have suggested improved sensitivity and negative predictive value, as well as lower rates of metastases to lymph nodes in tumors less than 2 centimeters. And in the NCCN, this is listed as a recommended size cutoff for sentinel lymph node biopsy. The Cervical study, published in 2021, was a Danish study with a specific aim to analyze the efficacy of sentinel lymph node biopsy in early-stage cervical cancer, with planned subgroup analysis of tumors between 2 to 4 centimeters. This was a prospective, non-randomized study which enrolled 245 patients. All patients underwent a preoperative EUA to determine surgical resectability and a pre-op PET-CT scan. Patients then underwent sentinel lymph node mapping with ICG, followed by removal of any suspicious lymph node. If a side didn't map, pelvic lymphadenectomy was performed. All surgeries were done minimally invasively, and all were performed in Denmark. Additionally, in all the tumors greater than 2 centimeters, bilateral pelvic lymphadenectomy was performed regardless of mapping. This study found similar rates of sentinel lymph node detection as previously reported, with 82% bilateral mapping. Overall, 15% of patients had nodal metastases, and in patients with greater than 2 centimeters, 27% had metastatic disease. Following the algorithm of side-specific lymphadenectomy for non-mapped sentinel lymph nodes was very accurate. Even in the group greater than 2 centimeters, the sensitivity was 96% and the negative predictive value was 99%. Interestingly, PET-CT was not very helpful for detection of metastatic nodes, with a positive predictive value of only 27% and a sensitivity of 15%.
This was a lot of information on sentinel lymph node, and we wanted to go over it in detail because this data is emerging and there isn't long-term safety or survival data for sentinel lymph node biopsy in cervical cancer. Because of this, there are varying practice patterns and rates of adoption of sentinel lymph node in the US. So it's really helpful to understand why providers at your institution do things the way that they do. Sydney, what about para-aortic lymph node dissection in cervical cancer?
Outcomes are worse for patients with para-aortic disease, specifically if para-aortic nodal metastases are greater than 5 millimeters. Rates of para-aortic lymph node disease are higher in patients with positive pelvic or common iliac lymph nodes and in tumors greater than 2 centimeters. If pelvic nodes are suspicious for metastatic disease, then a para-aortic lymphadenectomy is recommended, as this can change recommendations for treatment. We'll discuss treatment of positive para-aortic nodes in our next episode. The Parola trial is ongoing with results expected in 2030 and is evaluating whether para-aortic lymph node evaluation can be used to tailor chemoradiation to improve survival outcomes.
That's all we have for you today. We hope you learned something on today's episode of Ready Set GYO, a podcast for Gyn-Onc Fellows. Here are your key takeaways from today's episode.
Cervical cancer is the 4th most common cancer in individuals assigned female at birth, with 85% of cases seen in lower-income countries. In high-income countries, squamous cell carcinoma of the cervix is declining in both incidence and death rate due to effective screening programs, However, rates of adenocarcinoma and adenosquamous carcinoma are on the rise.
The most contributory risk factor for cervical cancer is HPV infection, with only about 5% of cervical cancers being HPV independent. The HPV vaccine is recommended for all individuals aged 9 to 26 and is available up to the age of 45. Screening for cervical cancer is done with cytology, plus minus HPV testing based on ASCCP and/or USPSTF guidelines, and HPV test self-collection was recently approved by the FDA.
The biggest difference to the FIGO 2018 staging system is that imaging can be used to assess for retroperitoneal nodal involvement. In addition, lateral extent of disease is no longer considered for stage 1A, and stage 1B disease is subdivided into 3 groups based on the size of the primary tumor in greatest dimension.
Lymph node evaluation is warranted in all cervical cancers aside from stage 1A1 without LVSI. A bilateral sentinel lymph node biopsy is appropriate for tumors less than 4 centimeters, but is more accurate in tumors less than 2 centimeters, based on several prospective studies. A full lymphadenectomy should be performed if there is failed mapping. This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross.
Our sound editor is Brogan Brown.
Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Brian Orr, faculty at the Medical University of South Carolina, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya signing off.